Hello, everyone, and thank you very much for joining us for our webinar today about new approaches to today's children's environmental health challenges. My name is Carol Strobel, and I'm with the Children's Environmental Health Network. This webinar is made possible through the generous support of the Centers for Disease Control and Prevention, but we do need to make clear that this is the content is the responsibility of the Children's Environmental Health Network and does not necessarily represent the views of the Centers for Disease Control and Prevention. Just as a quick overview, the Children's Environmental Health Network is a national nonprofit organization that was created to protect children from environmental hazards and to promote a healthy environment. We do a number of different activities, and I'm not going to go over in great detail of all of our programs, but we promote policy to protect children. We promote research to better understand children's environmental health and how to protect children, and we have programs and activities that educate and train people about children's environmental health, one of which is this webinar today. And we're very proud of the fact that in 2012 we're celebrating our 20th anniversary. Today's webinar, the goal is to give an overview of how children's environmental health is influenced through a number or by a number of different sectors. And we're going to talk a little bit today about opportunities to protect children's health, recognizing these different sectors. And you see on the slide the objectives where we're going to talk about some of the emerging science that motivates us to better understand these cross-sector impacts on children's health. And we'll talk about some examples and opportunities to better protect children's health through these cross-sector activities and to protect children's environmental health through sectors that are not traditionally thought of as influencing health. So today we'll hear from Cynthia Bearer, who is the chair of the board of the Children's Environmental Health Network, as well as with the University of Maryland. And we'll hear from Nsedu Witherspoon, who is the executive director of the Children's Environmental Health Network. And so and you can also see on the agenda, we will have questions and answers and further discussion later. So I will now turn it over to Cynthia Bearer. Cynthia?
Thanks, Carol. And I'm going to be talking about children and the environment and the unique health challenges and opportunities that they represent. So we've been talking for the last 20 years, since the beginning of our network, that children are not just little adults. And that means that they eat more food, drink more water, and breathe more air than adults. They also are in different places than adults, such as they crawl on the floor, whereas some of us have trouble getting down on the floor nowadays. And they put things in their mouths. One of the things that children do is explore their environment, and they do that by crawling on the floor and putting things in their mouths. And all of their systems, their nervous system, reproductive, and hormonal systems, are still growing in development. So they may be expressing proteins and processes that aren't present in the adult mature form of the body anymore. They also metabolize chemicals differently, just as they metabolize food differently because their bodies are doing different things. And so they can't metabolize the toxins they're exposed to as well as adults can. So why focus on children? Well, because of those reasons that I just went over, children have unique vulnerabilities and susceptibilities to environmental hazards. An adult may suffer little or different amounts of harm from an exposure to a chemical, such as lead, mercury, or alcohol, when that same exposure can cause lifelong damage to a child. For example, an adult can get drunk with alcohol exposure and recover the next day and be back to normal, whereas one binge drinking episode by a pregnant woman can be measured in demonstrable harm in her child after delivery. So what are children's environments today? What do we know about the toxic component of their environments? Well, we know there's 85,000 known chemicals. The majority of these chemicals that are commonly used have not been adequately tested for their impact on human health, much less children's health. We know that children are constantly exposed to potentially hazardous chemicals. In fact, in one recent study, they found 217 different chemicals in 10 samples of umbilical cord blood. So they're even exposed when they were in utero and should have that additional layer of protection from their mothers. These chemicals are not adequately regulated for their impact on children. So what are today's emerging pediatric health challenges? Well, one is the early onset of these health challenges. Another is that these impacts can lead to chronic changes in health. And we're dealing with children who are possibly the first generation to have a shorter life expectancy than their parents due to their poor health status. And a lot of this, the data that supports that statement comes from the epidemic of obesity and type 2 diabetes that we're seeing amongst children. So what are some more of today's pediatric health challenges? Well, lead is a known environmental toxin, and we know that there are about 500,000 children between the ages of 1 and 5 that have blood lead levels above the reference value that is now 5 micrograms per deciliter. In asthma, we knew that in 2009, more than 10% of school-aged children had a diagnosis of asthma. And for obesity, 17% of U.S. children and adolescents are obese. Autism has also caught the national interest. In 2008, 1 in 88 children were diagnosed with autism spectrum disorders, or ASDs. This is an increase in diagnosis. It had been in the year 2000 that 1 in 150 kids had the diagnosis, and 8 years later it was 1 in 88. And the reason for that increase is not well understood. Some people think that it's because of the way we're making the diagnosis, but other people think that that alone cannot account for the increased incidence of this diagnosis. So there may be different factors that make a child more likely to have ASD, and some of those factors could include this environmental exposures that they're experiencing, as well as biologic and genetic factors. So research indicates that there is an environmental role in asthma and obesity, meaning that there are toxins in the environment that make it more likely that an exposed child will have asthma and obesity. And there may be a role in the learning disabilities and autism. So these are a new host of challenges, and not just for pediatric health and medical professionals. So many health problems are multifactorial, just as we listed environment, biology, and genetic. So we think that environmental factors may play a role in about 25% of cases of developmental defects. And some common chemical exposures increase the risk of cancer even decades later. For example, I'm going to use in utero exposure to chlorpyrifos, or CPF, which is a common pesticide. And what I'm going to show you are slides that I got courtesy of Frederica Pariah, who was the PI for the Columbia Center for Children's Environmental Health at Columbia University in New York. So why did we pick chlorpyrifos? Well, we know it's an organophosphate neurotoxic pesticide, which means that it inhibits acetylcholinesterase. It was banned in 2000 for residential use, but is still used on food crops. And experimentally, prenatal CPF exposure produces adverse effects on fetal growth and neurocognitive development used in animal models. It affects brain development not only by that inhibition of acetylcholinesterase, but also by non-cholinergic mechanisms at levels that don't really cause much acetylcholinesterase inhibition. So there are mechanisms by which it affects brain development that haven't been clearly delineated yet, and for which we cannot use acetylcholinesterase inhibition as a marker. So high prenatal CPF exposure is associated with developmental delay and reduced child IQ. And that's been shown in 3 different cohort studies across the United States. So at age 3, in one cohort study, at age 3, children with higher levels of CPF in cord blood had 2 and 4 times greater odds of having mental and motor delay respectively than children with lower exposure. And at age 7, children with high prenatal exposure to CPF had lower full-scale and working memory IQ scores than children with low exposure. And these studies also accounted for the other things that we know affect these measurements of cognitive function, such as maternal educational level, maternal IQ, and the quality of the home caretaking environment. So all of those were equal between the 2 groups. The only difference was the exposure to CPF. So the conclusions there for CPF is that umbilical cord CPF concentrations were associated with an increased odds of mental and motor delay. So the higher the umbilical cord CPF concentration, the more likely the child was at risk for mental and motor delay. That there was an inversely associated relationship with working memory and full-scale IQ at age 7 years, meaning that the higher the CPF concentration, the lower the IQ level at 7 years. And that this association with IQ was approximately linear. So there was no evidence of a level of CPF in cord blood that didn't result in some impact on the child's neurocognitive behavior. So the U.S. chemical policy sets standards for CPF exposure, but these standards are based on adult healthy males and do not consider the developing system vulnerabilities such as those that are in children as they're developing. And it also doesn't consider children's differing behaviors or exposures, meaning the crawling on the floor where CPF may be in the rug, or putting things in their mouths that may be covered with CPF. The chemical policy also only considers one chemical at a time. We know there are a lot of pesticides that are organophosphate type of pesticides which will inhibit acetylcholinesterase along with CPF, and they're not taken into account when you're exposed to CPF. These policies also balance health with other considerations. They're not just health-driven. And they assume that chemicals are safe until we have enough human data to prove otherwise. So in 1996, this law changed, and U.S. pesticide regulation changed with the passage of something called the Food Quality Protection Act, or FQPA. And this said that pesticide food standards, the amount of pesticides that can be found in food, must assure that children are safe from the hazards of the individual pesticide across all aggregate exposures. So that means that they have to be safe from the level of CPF, including all the other pesticides that inhibit acetylcholinesterase. And then that children are safe from the hazards of multiple pesticides with cumulative risks. So it may be an organophosphate, but there may also be a pesticide that will affect neurodevelopment at a different site but compounds that with the acetylcholinesterase inhibition. Finally, there's a health-only standard of reasonable certainty of no harm. So this is a health-driven protection standard. And if the information that we have is incomplete, then an additional tenfold safety factor is applied, meaning that the standard or what you find in the food has to be tenfold less than the lowest amount shown to have some kind of toxic effect. So this FQPA, or the Food Quality Protection Act, gave the Environmental Protection Agency, or EPA, stronger tools to protect human health, especially children's health. So many pesticide tolerances have been revoked as a result of FQPA, and the use of CPF has been severely limited, and in fact it is now banned from residential use. So here's looking at some of what happened following the ban on CPF. And right now you're looking at 3 different, and I'm going to use my little marker tool. We're looking at CPF in personal air. We're looking at CPF found in maternal plasma. And we're looking at CPF found in cord blood plasma. And here in the orange is 1999, and that was right after the EPA ban on chlorpyrifos. And you can see in personal air samples as we move forward in time, and this is up to 2006, you can see that there was quite a drastic drop in the amount of CPF in personal air. And that's reflected in the drop in maternal plasma values of chlorpyrifos, as well as in umbilical cord blood chlorpyrifos. So this is kind of exciting news that the ban on CPF actually reduced drastically the exposure of babies in utero to chlorpyrifos. And now I'm going to turn this over to Ense, who's going to be talking about opportunities to improve children's environmental health. Ense Obet-Witherspoon is the Executive Director of Children's Environmental Health Network. Ense?
Thank you so much. Excuse me, Cynthia. Thank you for that great introduction. And I want to apologize to everyone up front. I'm dealing with a pretty bad cold, so I hope I can be heard well. As I get into this section, I want to make sure that I'm framing this well for everyone. I want to make sure that everyone understands that there are many sectors that shape children's environmental health, chemical standards and regulations, which of course influence greatly the content that is allowed on our products and our store shelves. Our land use and our community design, or how they're ill-designed, has a great factor on our children's health and well-being and their safety. Transportation considerations and the related air pollution that is caused by our transportation routes, especially with a lot of transportation, for example, in the DC metro area where there's a lot of commutes, those type of things. Housing, education, social economics, even access to food sources, and many more. There are many factors, so we just want to keep this all in mind. Now, while important, 10% of an individual's overall health status is contributed only by their health care. So I just want to make sure that we understand that we need to consider that there are 90% of an individual's overall health status that is involved with other factors, and certainly decreasing exposures to known environmental hazards becomes a big part of that overall health status. So when we look at some successful ways to reduce known exposure, looking at pesticides is a really good example for us. In particular, integrated pest management, or IPM, is seen as a very effective and environmentally sensitive way to control pests and weeds. And this is a process that does not prohibit pesticide use, but it certainly encourages the least toxic methods to be used first if needed at all. And for example, this would be a case where maybe there's an infestation, say in a school or a large housing unit, and unfortunately maybe the least toxic type of pesticide needs to be used up front. But the hope and the intent would be that after that, the process would not be so determined and dependent rather on the use of harmful pesticides moving forward. And this process uses techniques that pose the least toxic hazards to people, property, and environment, because let's not forget, the whole purpose of a pesticide is to kill, to stop the reproductive nature of an organism that it comes in contact with, and certainly people and animals cannot avoid that as well. So giving one example of how the use of integrated pest management has been effective, looking at New York City, a highly populated city, of course, in the U.S., just by one single use of some IPM techniques in 13 New York City apartment buildings, it was found that there was substantially more eliminated cockroaches and mice than in repeated professional applications of pesticides in other buildings. Another example was found in Monroe County Schools, Indiana. And this consists of 19 schools, and they found that there was a 90% reduction in the use of pesticides, and specifically these were pesticides including organophosphates and synthetic pyrethroids, and also reduction 90% in the pest problems itself, and then also 90% reduction in pest control costs. So before IPM implementation, they were spending about $34,000 for this school district on pest control each year. After IPM implementation, they were able to hire one in-house half-time IPM technician to handle the program for $28,000 a year, which included the cost of the technician as well as the IPM implementation costs as well. So that was definitely a win-win in that situation. So for looking for, there are a wide variety of other, well-viewed, well-respected resources on IPM management and implementation, and we would refer you to the Children's Environmental Health Network's Eco Healthy Child Care Program, which can be found on our website here at this link, or you can go just to the main website, CEHN.org, and then go into Eco Healthy Child Care and then specifically resources. And this program, just briefly, is the only national program of its kind working to promote safe and healthy environments in the child care setting, specifically working to train child care professionals on low cost and well scientific-based recommendations for how they can make changes tomorrow or progressively throughout the course of their business to make sure that they're promoting the safest and healthy environments possible, and using IPM is one standard that we highly recommend for that program. And then we also have an endorsement side to this program where individual child care centers can become endorsed through our program, and of course their use or intended use of IPM is a big part of that endorsement as well. Also, your state ag extension program is another resource we would recommend, and you could literally just Google, for example, Indiana Ag Extension Program, and these resources will come right up. So we do encourage you to check those out as well. Now, looking at land use, walkability, and our health, again, I started framing this discussion with the idea that children's health is impacted by a variety of factors, and how our land use is considered and zoned and planned is a big part of that. We know that, again, just for example, transportation's role has a big role in air pollution and the increased amount of air pollutants in our air, and that can significantly influence a child's either incidence or severity of asthma, for example. We also know that whether a community is designed for walkability and biking or not designed in that way is a big factor on whether children and community members and families are able to physically get out and have safer routes to walk and, again, be physically active. This is an unfortunate slide here, but it is the reality that we're looking at. Specifically, this is the U.S. map in 2007, and you'll see that a majority of the states here are shaded in some form of dark or medium dark blue, and the darkest blue there represents body mass index, and this is about 30 pounds overweight for the average 5'4" person or more. So body mass index over 20 to 25% are the darker, for Texas, for example, and some of these other darker states. And then also in the lighter shades, the lighter blue, these are representing anywhere from 15 to 20% over average body mass index for the U.S. So of course, and this is coming from the National Survey for Children's Health in 2007. So the writing's on the wall. We are becoming increasingly heavier, and our younger generations are becoming heavier the quickest. Our adolescent young girls and then our boys are right in suit there. So we have a serious epidemic on our hands. In 1969, 48% of children 5 to 14 years of age usually walked or biked to school. But now in 2009, 13% of children in that same age group usually were walking or biking to school. In 1969, 41% of children in grades kindergarten through 8 lived within 1 mile of the school, and of those, 89% usually walked or biked. It was tremendous. But in 2009, 31% of children the same age range only live within 1 mile of school, and within that, only 35% of those children were usually walking or biking. So the trends are definitely overlapping as far as how our communities are designed now. A lot of more cul-de-sac, a lot more building out from the urban centers, a lot of disconnecting communities, and the impact that that is having in one respect on the health and well-being of those community members, in particular our children. Now, this is important, the most common barriers to walking to school, because we do have to recognize there are a variety of factors here depending on where you are and the cities you live in. The distance to school was the largest barrier to kids walking or biking or some other physical form besides a motor vehicle to school. Traffic-related danger is the second, and then followed by weather, crime, opposing school policy, which I find interesting, and other reasons not identified in this survey that was taken by the CDC in 2004. So we do want to highlight the Safe Roads to Schools program as a best practice. This program, considering the last couple slides, is working very hard to look at some real infrastructure changes in the communities that is enacted in. It works to sustain efforts by parents, schools, community leaders, local, state, and federal governments, really looking to improve health and well-being. That is the overview of this entire goal of this program. And it really looks at each individual school district or the area that is being implemented in on a case-by-case basis, really looking at the conditions around the school, assessing and conducting projects and activities that work to improve the safety, the accessibility, and reducing traffic and air pollution. So it really is a multifactorial set of impacts when implemented. And I really in particular like their 5 E's of the program: evaluation, engineering, education, enforcement, and encouragement. And again, these are the methods for eliminating environmental hazards as they're increasing and implementing this program. But I think we certainly think that the way that they've thought this out and really looking at all the various phases that a community, especially one that's just coming in contact and is just increasing their knowledge on these issues, would have to start working through in a very comprehensive way. So one good example, as they've been evaluating this program, is in Boulder, Colorado, Heatherwood Elementary School. In the first 3 years of implementing the Safe Routes to Schools program, students regularly were walking and biking, and that actually increased from 12%, but then went to over 43% once they started implementing Safe Routes to Schools. In 2011, 90% of people participated in a walk and roll in this school district, and so that really included some friendly competitions, documenting active trips to school at least once. So really encouraging the increase of walking and biking and using another form other than motorized vehicle to get to school, which was fantastic. Now, again, as they continue to evaluate this program, there are studies that are showing that implementation of the Safe Routes to Schools program is actually helping to reduce in 50% the number of child cyclists and pedestrian collisions, which is quite important when we talk about injury and some of these concerns once people are walking and biking a little bit more. Also, these evaluations of this program is showing that it's increasing walking and bicycling from significantly from 20 to 200%, and reducing parent drop-offs and traffic congestion, and of course improving air quality at the same time. And then 55% of children are normally bused in this country, costing $21.5 billion each year. And this program is showing that just by eliminating one bus route alone saves about $45,000 a year for a school district. But if not combined with other measures in this program, it can still worsen congestion and safety, because you don't want those children to then be riding in cars or some other form of motorized vehicle. The point is to get them walking and biking when at all possible. So there are a variety of resources on the Safe Routes to School website that we would highly encourage that you check out, and certainly connecting with the program staff who can help you navigate and or connect you to some of their on-the-ground partners and champions would also be a great benefit and something we would recommend. But in particular here, the Quick Startup Guide is intended to suggest immediate safety improvements when your community has cut back on busing, but the action steps are relevant to anyone working on Safe Routes to School. And the local policy guide is helpful for those who want to look into policies that can help sustain their Safe Routes to School program over long term, which of course would hopefully be the goal for each community that implements this program. And the third resource, the air quality resource, is a guidebook on air quality and safe routes to school. So these are just some we teased out. We would definitely recommend, again, going to the website and talking to the program staff specifically. Now changing a bit to land use and just taking the example of child care facilities and where they're sited. One important piece here to keep in mind is that there are no national standards for assuring that a child care facility is not located on a site that could harm children due to adjoining or previous uses. And this is unfortunately with the overview here of a New Jersey child care center that was actually found to be in a former warehouse that was heavily contaminated with mercury, and this got a lot of media coverage, and unfortunately kids had to get very, very sick before the state then retroactively went back and figured out what had happened. This is an extreme case, but unfortunately cases like this are happening frequently all over the country, and the bottom line here is we have to do much better for our kids. They cannot continue to be our guinea pigs, if you will. There are other sites of concern, of course. Any type of child care facility, for example, where, again, very young kids, anywhere from 6 weeks to kindergarten age, are spending 40 hours or more a week in this country. Any facilities located near dry cleaners, smelters, mills, factories, gas stations, a wide variety of these type of locations listed here. Also, vacant lots are concerned because of the contamination for previous use or illegal dumping activities. And let's not forget the quote-unquote pristine land which may be seen as, not toxic, at least to the human eye, but certainly may be also contaminated. You don't know, it's not sure. We may not be so sure what's in that soil unless it is tested. It could be contaminated with other pesticides and chemicals from previous use, and we need to be aware of all of that. New York and New Jersey are the only states that have some regulations on siting of child care facilities. It's my understanding that there are other states that are in discussion and are certainly working towards that goal, but we have a long way to go, bottom line here, and our child care facilities need to be very careful in where they are selecting themselves to build if they are doing so or renovating or taking on a new facility. And also we'd like to connect you with some additional resources when you're looking at land use and asking some core questions, whether it's child care facilities or other type of facilities housing especially our young children for long periods of time. The Connecticut SAFER program, the Screening, Assessment, and Environmental Risk SAFER program is one we would direct you to, as well as for additional guidance on siting of new child care facilities and even for identifying potential hazards in those facilities that already exist. We encourage you again to go back to our Eco-Healthy Child Care program, and specifically our siting portion of our child care program on our website. And I thank you for your participation and your attention to these issues. Thank you very much.
Thank you, Ense, and thank you, Cynthia. This is Carol Strobel again, and we just wanted to highlight some resources for you to get more involved in these issues. Some of the things you can do is you could join our listservs. You can go to our website at CEHN.org, where by joining our listservs, you will get updates on activities and resources, things that are happening. And the listserv is somewhat active, but it's not going to be the kind of listserv that fills up your inbox every day. I can promise you that. We have just released 2 new documents that provide an overview of the impact of different sectors on children's environmental health and the need to consider these different sectors and opportunities for protecting children's health. We've just posted them to our website at the site listed there, cehn.org/policyshapeshealth. We also release an article of the month where our scientific advisors have identified a recent study that they feel there should be increased general awareness of the study and its findings. And so you can look for our article of the month to learn about what's happening in what emerging science is telling us. We also are active on Twitter and on Facebook, and we encourage you to participate with us there. And we also work with a number of different partners, particularly the list of organizations here, all of whom have projects related to this kind of cross-sector work on protecting human health. These organizations are all listed in the documents I mentioned in the last slide, these new publications that we are just getting out about cross-sector activities, and these organizations and their specific websites in this work are listed on those documents, which you can download from our website. We will turn to questions and answers soon. We ask you to submit your questions in the chat, in the chat box on your screen. And we also ask you to participate in the evaluation that you will receive at the end of the webinar, because we really appreciate your feedback to help us understand how we are doing and what we can do better. And we particularly appreciate your help on this. This is our first webinar, and our learning how to use this technology. And again, I will mention that we are very grateful to the Centers for Disease Control and Prevention for supporting our work in this arena, but we must make sure that you are aware that the content of this presentation is ours, does not imply that this is official views of the Centers for Disease Control and Prevention. And we will be posting this webinar on our website. And I now invite you to turn to part 2 of this webinar, which is where we have the discussion of the Q&A portion of the webinar. So thank you very much.